Hello, everyone. My name is JoEllyn Moore. I am an electrophysiologist in the Department of Electrophysiology at the Minneapolis Heart Institute in Allina Health. I'm also part of the Joseph F. Novogratz Family Heart Rhythm Science Center, which is part of the Minneapolis Heart Institute Foundation. And it's my pleasure today to give you a bit of a whirlwind tour of atrial fibrillation, including some hopefully key insights into diagnosis and treatment. In terms of disclosures, I have given lectures for Medtronic, and I do conduct some clinical research funded by Medtronic. But of course, I always tried to be objective in my presentation of the data and material. So what are our objectives today? They may be quite ambitious, but we'll do our best. First is to review the basics of atrial fibrillation. I'd like to outline for you the current ablation technology, and boy, is this changing fast. And finally, I will talk a bit about left atrial appendage occlusion and its role in preventing stroke. But before diving into details about treatment, let's just review some basic topics about the heart and electrical system of the heart. So, of course, the heart is a muscle that pumps blood, as you can see here, as it goes through its cardiac cycle. And the heart, as you may know, is powered by electricity that moves from the upper to the lower chambers of the heart. And just as a building has electrical wiring that you can see here, our hearts also have electrical wiring. And as the electricity moves from the upper to the lower chambers of the heart, or from the top to the bottom, the heart squeezes in synchronicity with itself. So it goes upper chambers, lower chambers, upper chambers, lower chambers, as you can see. And as you can imagine, you can have problems anywhere along the electrical system, and there would be a whole separate talk to discuss the need for pacemaker if you have conduction blocks in that electrical system. But some types of disturbances can cause fast heart rhythms, and specifically, one of them is atrial fibrillation, which is really a disorganized electrical storm in the upper chambers of the heart that typically originates in the left atrium or the left upper chamber. And again, you can see normal rhythm. There's just one signal firing going smoothly to the bottom chambers. And in atrial fibrillation, it's just chaotic firing in the upper chambers, bombarding this electrical bridge, and in many cases, making the heart to go fast. Let's speak briefly about some of the basics in terms of demographics for atrial fibrillation. Atrial fibrillation is the most common sustained arrhythmia, and the incidence of atrial fibrillation does increase with age. It's estimated to impact 4% of the population who are greater than 60 years old, and it impacts probably more than 40 million individuals worldwide, and I suspect is underdiagnosed in many contexts. It is associated with significant morbidity and mortality, and has increased risk for debilitating symptoms if you have atrial fibrillation, includes stroke, heart failure, and in some cases, death. What are the symptoms of atrial fibrillation? I would say they're all over the map, and if you talk to 20 different patients of atrial fibrillation, you're going to get 20 different experiences based on patients' unique circumstances. Some patients have no symptoms. Others just have a few fluttering or palpitations, fatigue, lightheadedness, dizziness, chest pain, breathing difficulty, sweating. Some patients, although it's rare, can faint when they go into atrial fibrillation or when they convert back into normal rhythm. Some patients describe frequent urination when they go into atrial fibrillation, and some patients retain fluid when they go into atrial fibrillation. What are the risk factors for atrial fibrillation? There are many, but the most common ones would be elevated blood pressure or undertreated high blood pressure, sleep apnea, particularly sleep apnea that's not treated appropriately, structural heart disease, such as a weak heart or abnormal valve function, and patients with congenital heart disease, even if it's been corrected, are more likely to have atrial fibrillation. excess alcohol, diabetes, prior heart surgery, such as even bypass surgery, increased weight, thyroid disorders, extreme exercise. Actually, extreme athletes have a slightly higher incidence of atrial fibrillation than those who are not, and family history. How do we diagnose atrial fibrillation? We really have to do this based on an EKG tracing, either on telemetry, which is a continuous strip of your heart rhythm, or by a 12-lead EKG. And for patients where their atrial fibrillation is not continuous, they might jump in and out of atrial fibrillation. We'll often recommend a wearable cardiac monitor. And I would say most monitors at this point can be done through a patch that would be worn for a certain amount of time and then sent back in for analysis. One innovation is the resurgence of technology for personal use. EKG watches have been become so frequent and accurate in terms of diagnosing atrial fibrillation. And I've had many patients come in with their own tracing and tell me that they have atrial fibrillation, and sure enough, when we look at their tracing, they do. There's also a little 2-electrode strip that you can buy that's called a cardio monitor that allows you to take an EKG, 1-lead EKG of your rhythm. So how do we manage atrial fibrillation? We really talk about the ABCs of atrial fibrillation. A is avoiding stroke and anticoagulating in the appropriate circumstance. B is better symptom control. And C is comorbidities and cardiovascular risk factor management. And I would say for the purposes of this talk, we're going to focus on A and B and speak a bit less about C, although that is incredibly important. So in terms of reducing the risk of blood clots or stroke, one of the first things that we do whenever we first diagnose a patient with atrial fibrillation is decide whether they need to be on a blood thinner. There's a special risk score that we use to assess that. There are many blood thinners that we can use. The oldest one that has been in use for the longest is warfarin, but there are newer examples such as apixaban and rivaroxaban, edoxaban, dabigatran, and you can talk to your physician about the nuances of the different ones. For patients who don't tolerate blood thinners or say they have had a bleeding issue on a blood thinner, a left atrial appendage occlusion is an option now, and we'll talk about that at the end of this talk, which is a percutaneous procedure to block the area that causes stroke. Our second goal is to control symptoms and heart rates, and many medications we have to lower the heart rate or stabilize the rhythm. And some of these would be beta blockers, calcium channel blockers, sotalol, and amiodarone. Just like the symptoms, I always tell my patients, if you talk to many different patients with atrial fibrillation, they're almost certainly going to have all different strategies to control their symptoms. And although we usually try medications first to control symptoms from atrial fibrillation, some patients are stuck in atrial fibrillation continuously, and we might recommend an electric shock or cardioversion. And for patients who continue to have atrial fibrillation that is symptomatic and have either been intolerant of medications or they choose to have a more definitive procedure than an ablation procedure is often recommended. So what is the target for ablation for atrial fibrillation, and what is ablation? So here's a nice diagram showing the back wall of the left upper chamber of the heart, the left atrium. And you can see most patients have 4 veins that bring oxygenated blood from the left atrium, from the lungs to the left atrium. And what we learned in the 1990s was that misfire beats from those veins seem to come out and trigger this electrical storm. And Dr. Hazeguer in France was one of the earliest physicians to recognize this physiology. So the goal for ablation, when we put a catheter up into the heart to try to block these beats, is to create intentional scar around these veins to block not the blood flow from the veins, but to block that electrical current from triggering atrial fibrillation. So the procedure that we do is called pulmonary vein isolation. So here is a three-dimensional map that's characteristic of what we might do when we do an ablation for a patient with atrial fibrillation. And what you can see here is purple is healthy signal. And before the ablation, you can see there's this purple signal going out into the veins. And after we've completed the ablation, now there is a scar or no signal getting into the veins. So how do we achieve this pulmonary vein isolation? And there are many different ways we can do it. One is with radio frequency or heating ablation. The second is with cryoablation or freezing ablation. And the third is a rapidly changing and evolving field of pulse field ablation. For all of these approaches, we access the heart primarily by putting IVs in a vein in the leg and then running catheters up into the heart, sometimes using X-ray cameras and small ultrasounds, as well as three-dimensional mapping systems. And what we have to do is poke a tiny little needle across the septum, which is very, very thin, put a long IV over that needle so we can access that left upper chamber to start to work around these pulmonary veins. Radio frequency is really a heating ablation that uses longer wavelength, lower frequency, lower energy signals to contact the tissue and heat it up, ultimately damaging the cells and causing a scar to form. Cryoablation is a freezing ablation, most commonly using a balloon that is placed into just outside the vein, and that freezing creates scar. And pulse field ablation is another name for irreversible electroporation, which is using a precise electric field to target cells. And this causes the cell membrane to form pores, and then the cell contents exit the pores and lead to cell death, which does heat the tissue around it very slightly, but not as much as radio frequency. The pulse field ablation catheters are many, and I would say all of the ablation companies are on a race to decide whose catheter is going to be the best. And I would say we really don't know yet. The catheter that was earliest to be FDA approved is the FARAPulse catheter by Boston Scientific. And I would say that's the one that's being used the most across the country just because it was the earliest. The Sphere 9 catheter by Medtronic has now been approved for use. And then there are many others that are very close on the heels of these. How effective is atrial fibrillation ablation? I would say for pulse field ablation, I really can't give you the long-term outcomes for our data. For radio frequency, which is the primary modality that our group uses, in our cohort from our own patient data, about 5 to 10% of patients require more than one ablation in the first year. Up to 25%, though, are still on a medication to suppress atrial fibrillation at 1 year. And so the important point for that is that we never say cure when we talk about ablation. We can often get a very good long-term success, but in some cases, patients still have some short episodes of atrial fibrillation that require medication for treatment. And the other important point to make about atrial fibrillation ablation is that it does not prevent stroke, and that doing an ablation for atrial fibrillation is not in order to get a patient off of blood thinners if they already have an indication to be on one. A very nice study that just came out in 2023 looked at long-term outcomes for atrial fibrillation, which again is really instructive when patients ask, is atrial fibrillation something I'm going to have to manage over my lifetime? And unfortunately, the answer is yes. Now, that doesn't mean they're going to be having symptoms every day, every year over their lifetime, but it's something that they'll need to continue to monitor and ensure that they're not having recurrence. And you can see here, if you look at even patients with what's called paroxysmal atrial fibrillation, which is a very early form of atrial fibrillation, if you look down the line 16 years, almost 50% of those patients will need more than one procedure to treat their rhythm. And if you look to people who have been in atrial fibrillation for more than a year, who have an ablation at that time, 20% of patients will not have needed one more ablation within 16 years. So the reablation rate is quite high. With their newer catheters that we've been using in the last, say, 8 to 10 years, the redo rate is less. So let's move along from ablation to talk briefly about left atrial appendage and its role in the increasing risk for stroke. And I showed you some images earlier on in this talk showing you that this left atrial appendage can be a source for stroke. You can see it's just a little pouch here. And if you look on the inside of the pouch, it has all tiny little pockets and crevices where clots can form. And you can imagine when you go into atrial fibrillation, this pouch is suddenly quivering. Blood is not moving through here nicely, and so clots can form due to reduce contractility and stasis. So what happens, I mean, if we recommend a patient that should be on a blood thinner to prevent stroke, what happens if it's not tolerated? If they have a gastrointestinal bleed, intracranial bleeding, or a spontaneous bleed, frequent falls, horrible bruising, or really bad side effects from the medication, or if they have a really high risk for bleeding. Well, one wonderful thing now is that we have options to treat those patients to try to prevent stroke without, or at least with less blood thinner. If they're needing open heart surgery, there are ways that the surgeons can either suture off or clip the left atrial appendage. But we do have to ensure after the procedure that that appendage is fully isolated or fully excluded, I should say, to make sure that the patient doesn't need to still be on a blood thinner. If a patient doesn't need open heart surgery, then we have a percutaneous option. And the one that is used the most is called the Watchman device, which is a little basket that plugs off this left atrial appendage to block the area that causes clots to form. And I will say, too, the way that we access the left atrium for this procedure is essentially identical to the way that we access the left atrium for ablations. What is the success of this Watchman device? This is a nice registry that came out of national registry data demonstrating that 97% of patients who have a Watchman procedure have a procedural success with quite a low rate of major adverse events, less than 1%. Slightly higher rate of some type of adverse event in the hospital, although this may be in some ways related to the increased risk factors of that patient population. After a Watchman is placed, there is some type of imaging modality to make sure that there isn't a leak around the Watchman. If it's greater than 5 millimeters, that's considered high risk for recurrent clot formation, and so the patient would need to still be on a blood thinner, but that happens very rarely. So in summary, atrial fibrillation increases with age and can be asymptomatic, although it's frequently symptomatic. Treatment of atrial fibrillation revolves around risk factor modification, symptom reduction, and stroke prevention. And rapidly changing technology is increasing treatment options to improve quality of life and decrease stroke risk. Despite treatment, atrial fibrillation is likely to recur, so long-term monitoring should absolutely continue. Thank you. And I'd like to say a special thanks to Drs. Pai, Zakeb, Sengupta, and Olson, who contributed some of the slides that I used today. And at this point, we'll move on to questions.
Thank you, Dr. Moore, for your time and expertise during today's On the Pulse session. Fantastic presentation. And hello, everyone. My name is John Rickert, and I'm the Digital Education Program Manager here at the Minneapolis Heart Institute Foundation. And we'll just be jumping on here to help facilitate the Q&A portion. So the questions that we have prepared today were all submitted prior via the registration process and other outlets. So thank you to our registrants who did submit a question. However, please feel free to also add additional questions using the Q&A pod, which is located at the bottom of your Zoom screen, as these questions may be addressed in a future On the Pulse session. So Dr. Moore, the first audience submitted question that we have is, how will AFib affect my ability to exercise or be physically active?
So in general, I would say the goal is to allow patients to continue to be as active as they want to be. We really don't want atrial fibrillation to cause a change in lifestyle. Now, when we're first treating the atrial fibrillation and getting the rhythm under control, or maybe getting the heart rates under control, we might recommend that they decrease their activity just for a short period of time. But ultimately, our recommendation is that patients continue to live a very active lifestyle, exercise, and be able to do all the things that they enjoy.
Absolutely. So along those same lines, are there any dietary or lifestyle changes I should make to help manage AFib?
Well, I would say in terms of dietary changes, really the biggest offender can be alcohol. I mean, in moderation, that really usually doesn't impact atrial fibrillation burden much, although in some of the clinical trials, any alcohol use can increase atrial fibrillation incidence compared to no alcohol use. But I would say moderation of alcohol, and certainly making sure that your diabetes is well controlled if you have diabetes, keeping a low salt diet if you are someone who has hypertension, just to make sure that your blood pressures are well controlled. So those are some of the changes I'd recommend.
Definitely. And thank you very much for that insight, Dr. Moore. So the next audience submitted question is, what does the epidemiological data show about AFib regarding gender, race, or other demographic trends? Do you have any insight into that?
So overall, men have a higher incidence of atrial fibrillation, and they're more likely to develop atrial fibrillation at younger ages. But in older age, women live longer in general, and so the prevalence between men and women becomes more equal as patients get older. So that's the gender gap, so to speak. In terms of race, there is a ERIC study, which is an NIH-founded study and funded study, found that the lifetime risk of atrial fibrillation was 1 in 5 for Black Americans compared to 1 in 3 for white Americans. So it seems to impact white Americans more. And it seems that that is also true that white Americans compared to Asian Americans, the incidence is higher.
Thank you very much for that. So let's see here. We just have a couple more questions. And the next question that our audience submitted is, are there any good online support groups for people with AFib, or could you address the psychological challenges with living with AFib?
So I'm sure there are many other resources that I'm not aware of, but there is a online support called supportnetwork.heart.org. That is an online support mechanism for patients. And there's even a conference called Get in Rhythm, Stay in Rhythm. That's a patient-centered conference with many physicians who give lectures to try to educate the patient population about atrial fibrillation. I believe the next one is in August. So that's a great resource.
Excellent. Yeah, thank you very much for that. So let's see here. The next question we have is, what are symptoms for which one should call the cardiologist or go to urgent care or the emergency department?
I would say really anything that is way out of the ordinary for a patient. I mean, some people are in atrial fibrillation all the time, and so they live with atrial fibrillation every day, and they're on a blood thinner, and they're perfectly safe to go about their life. But for someone who has episodic atrial fibrillation, if they have horrible symptoms, if they feel very lightheaded or short of breath or chest pain, obviously those are things that I would recommend that they be evaluated very quickly.
Definitely. Definitely. So in your talk, you talked about technology, and I know it's a rapidly advancing field. So this next question has to do with artificial intelligence, which I know is a very hot button issue these days. So do you have any insight into how AI will influence the future of AFib treatment? And I would even add to that diagnosis.
So my impression is that AI is being used by the wearable technology that I mentioned with EKG watches to analyze large amounts of data to detect atrial fibrillation. There's also a big initiative at the Mayo Clinic to use a baseline EKG in normal rhythm to try to predict who might develop atrial fibrillation in their lifetime, just using an AI resource and looking at thousands and thousands of EKGs. So those are two places where I know that AI is being used.
Absolutely, and that's certainly exciting. So let's switch gears here a little bit and talk about research. So are there any future research studies that you are especially interested in or involved in?
So, one really exciting study is the option study, which is a study where patients are going to potentially be given both a Watchman device to block their left atrial appendage and have an atrial fibrillation ablation at the same time. Because you can imagine you're already in there. Why not just do both? And if you can do it safely and effectively. So that's an exciting study. And another exciting study is potentially using AI and wearable technology to detect episodic atrial fibrillation to see if we could safely use blood thinners in an episodic fashion. So for someone who is primarily in normal rhythm, but maybe they have brief episodes of atrial fibrillation infrequently, there's a study called React AF where they will wear a EKG watch and have analysis done of their rhythm. And if they do go out of rhythm, they'll only take blood thinners in that moment for a month afterwards, after they have atrial fibrillation.
Wow. Well, that's very interesting, and thank you very much for that insight, Dr. Moore. So the last question we have is just, do you have any final words for our audience before we sign off?
I would just say that there's every reason to be hopeful, even if you have a diagnosis of atrial fibrillation. We have so many options for treatment, and whether it be medications or more invasive options. And I feel that even in the last year, the way that we're approaching atrial fibrillation with ablation has been improving. And so I just think there's every reason to be hopeful and to certainly advocate for yourself and get in to talk to someone who is an expert in atrial fibrillation to understand the options that are best for you.
Absolutely. Well said. So that's all the time that we have for today, folks. A big thank you again to Dr. Moore for presenting on this excellent topic, and thank you to all of our attendees who joined us this afternoon. We appreciate your participation. And with that, thank you everyone, and have a great rest of your day.
All right. Bye, everybody.
Thank you.